Welcome to the Dr. Noel program. We were fortunate to have Dr. Brett Courtenay back to continue our discussion on arthritis and when it's necessary to have a joint replacement. As a quick introduction, Dr. Brett Courtenay is a orthopedic surgeon at St. Vincent's Hospital and has academic attachment to the University of New South Wales and the Notre Dame University. Dr. Courtenay's special interest is in hip and knee joint surgery and trauma. Welcome back, Dr. Courtenay, and thanks for accepting our invitation. And I think we'll take it back to continue from last time. And maybe we will start with saying, when do people should think about having a joint replacement?
Yes, joint replacement is the ultimate surgical solution for chronic deteriorating arthritis, and particularly in the hips and knees. And what drives people, what indications patients look for, is pain that can't be settled by normal conventional means, and also pain that then leads to a loss of function. That might be a pain that stops them walking, it may be pain that stops them playing their favourite sport, golf or whatever else it has to be. In addition to that, for many patients, it's the difficulty of sleeping at a night time, broken sleep, restless of an evening, that often triggers patients to seek a surgical solution for their problem.
What's involved with joint replacement?
Yep. With a joint replacement, you actually replace the worn ends of the bone with artificial material. You place it with generally a combination of metal and plastic, particularly in the knee joint, and you have plastic bearing surface on the upper end of the tibia, the shin bone, and metal on the lower end of the femur. In the hip joint, there are other alternative bearing surfaces that are used, but the majority worldwide is still a metal ball against a plastic cup.
Now, there are some people who would advise that not to have a joint replacement and leave it to the last minute when you cannot handle it anymore. Now, what do you think are the impact of delaying? Now, is it to an advantage or disadvantage for people to delay or to do it when it's as soon as possible to have a joint replacement?
I'd always recommend for a patient to leave as long as is practical. It is a big operation, and like any operations, there are risks and there are potential complications for it. So we generally, as surgeons, wouldn't recommend people to undertake that until they've tried all other avenues. If they delay, there's no so-called window of opportunity unless that patient becomes so immobile that they really have stopped walking. If they've get to a point where they are so limited and they have more than one joint, then sometimes they aren't in the physical condition to actually undertake the surgery and the rehabilitation. But delaying as long as you can while you still have good function, there's certainly no problem with that. And it doesn't matter how bad the arthritis is. It doesn't matter how much bone destruction there is or even deformity. There are so many variations and so many options available that it would be most unlikely that one couldn't get an operation for it. But patients still need to be mobile at the time when they have their surgery and have the strength to go through the operation. Because for a period of time after the operation, their mobility is going to be limited and restricted. So they're going to go a bit backwards before they come forward.
So can it ever be too late to benefit from joint replacement?
It's all subject to the patient's general condition. And if a patient's level of mobility has become so poor that they're no longer walking, that they haven't got the strength to get up and get going, then there will be a problem. Because for a period of time after the operation, for probably 3 or 4 weeks at least, the patient's general mobility will be worse while they're recovering from the acute impacts of the operation. So they really have to have that motivation, mobility to be able to go a bit backwards before they go forward. So if they are virtually chair-bound or house-bound or bed-bound, they're probably not going to benefit from major surgery.
So what are the final triggers that patients seek joint replacement?
Certainly my experience, I think there are a couple of things. One is the person who, say, loves their golf or loves their bushwalking, who just finds they can't do it, who finds that despite taking medication, modifying what they're doing, they're just no longer enjoying the activity that they've put up with it. Often people who are looking to travel just realise they can't walk the distance, so they're not going to get the benefits out of travel. And the other thing that I find with a large percentage of patients, it's their ability to sleep at night time. They are woken up, it's broken sleep. And I'd probably say in my group of patients, 75% of them would be triggered to have joint replacement surgery because of the final straw being their inability to sleep at night time.
Dr. Courtenay, are there different types of joint replacement?
Yes, there certainly is. There's a lot of different types of joint replacements on the market. In the hip joint, it's essentially a ball on a socket. In the hip, there are different materials that are used. You can have a metal ball against a plastic socket. You can have a ceramic ball against a ceramic socket, or you can have combinations. There was metal on metal, but they're no longer on the market anymore. But the majority that we would use in hips would be metal against plastic or ceramic against ceramic. In knee joints, it's all metal against plastic. But even in a knee joint, you can have a full replacement where both sides of the joint are replaced, the inside and the outside of the joint, or a partial replacement where only one part of the joint is replaced, and that is the diseased part of the joint. In the hip, the differences between the materials is not very much. Ceramic on ceramic will last much longer than metal on plastic. In today's plastic, that will last the majority of patients' lifetime. So it's extremely rare for them to wear it out. Ceramic on ceramic will last much, much longer than the patient will. Ceramic on ceramic does, however, have the potential problems of squeaking or clicking. And if the patient is unlucky enough to have a fall, there's always a risk of cracking the ceramic. As I tell my patients, you won't wear out your bathroom tiles, but you can get a little cracks through the tiles. And if you get cracks and if you get little shards of ceramic that break off, that's actually harder than the underlying steel, so it can actually wear the metal away underneath. They're very rare complications. In knee replacements, you have that difference between a full replacement and a partial. A partial is a little quicker to get over it, and the function of the knee is closer to normal afterwards. However, they have a much, much higher risk of reoperation. I would recommend a partial replacement on a patient, particularly if they wanted to try and get back into some of the more vigorous activities. A patient is more likely to play singles tennis with a partial replacement than with a full replacement. Whereas if their desire is only to get back and play doubles, they're more likely to have a full replacement. The big difference, but, is that reoperation rate. The reoperation rate for a total knee replacement is about 3 to 5% at 12 years in the joint register. For a partial replacement, it's about 25%.
So, are there any biological effects on the different types? Like, would your body reject a prosthesis, or would it impact on other physiological things in the body? Or
no, the ones we're using at the moment, it won't. The body will not reject the prosthesis because the molecules, even of the plastic, are not complicated enough so that the body will set up an immune reaction against the prosthesis. And that's what's required for something to be rejected in the body. There was a metal-on-metal hip that's been recalled from the market a few years ago. That had a particular special problem. That was a chrome cobalt steel that articulated with a chrome cobalt steel, and that there led to, in some patients, extremely high levels of chrome and cobalt in their blood, probably because of some impingement of the metal on metal. And that was a problem. But that was separate. That was somehow or other related to the manufacture or the design or whatever of the implant, or maybe the way it was inserted. Very difficult to be certain. But it was due to the very high levels of chrome and cobalt, and the body couldn't tolerate them. But metal on plastic, ceramic on ceramic do not suffer from those problems. And in fact, in the body, they are actually very inert. Plastic 2 decades ago was quite different from the plastic we have today, and that actually did cause some slow and steady reaction, which meant that the plastic of about 20 years ago really only lasted for about 15 years. But plastic today, they've overcome those problems, and the plastic of today will last really 20 or 30 years.
Thanks for your assurance that they're safe these days. How much of return of function can patient expect?
Yeah, it's quite different from a hip to a knee, and hips and knees are by far the most common joint replacements. Shoulders and there's some elbows and some ankles done as well. But in hips and knees, for a hip, the patient will generally get back pretty near to normal function. We say it's up to over 95%. And it's not uncommon for a patient when you say, okay, which hip it was, they almost have to stop and think for a minute because the hip feels so normal. A knee, however, is different. A hip is a ball in a socket, and modern manufacturing can very accurately produce a ball to fit in a socket. Knees, however, are different. The native human knee is a very complicated joint. It has menisci inside, which are commonly called cartilages, and ligaments inside. So for the manufacturer of something to reproduce that, they do a pretty good job, but they only get it to about 85%. So it will work. Patients won't look obvious that there's something wrong with the joint, but patients will give a story that they'll say it feels mechanical, it feels unnatural. It will do everything they want to do, but it won't feel normal. So it's good function. It's capable of lasting probably for the lifetime of the patient in pretty well everyone, but it's still not good for the more complicated functions that we might do. So it won't damage a knee joint to run on it, but patients will never feel comfortable to run on a full knee replacement. So it's about 85% of normal, whereas hips are about 95, 97% normal.
Thanks, Dr. Courtenay. And we'll just have a short break. I will come back soon. Welcome back to the Dr. Noel program. We have in this episode, Dr. Brett Courtenay, and we're talking about surgical joint replacement. Dr. Courtenay, so from what I understand, that some joint replacement might last the life of the patient. Can you elaborate on that?
Correct. The modern prosthesis should last forever. In hip replacements, the plastic that we use today is referred to as highly cross-linked. The implant companies have learned how to sterilise plastic without weakening it, and the engineers test it. They'll test it for 20 million cycles, equivalent to 20 years of high level of activity, and they will not measure appreciable wear. They'll test it to 30 years or 30 million cycles before they can start to see some wear. So with high level of confidence for the majority of patients, it should last forever. Ceramic on ceramic will last forever. It'll last for 100 years or more, so that's not a problem. The chipping and fracture is a small but real risk. In the knee, it's metal on plastic, and the same thing that applies with the prostheses for the hip. The plastic will last probably forever. It will be extremely unlikely for a modern prosthesis to wear out.
That's very impressive. And then just remember that patients have 30 million functions they do.
Right.
Like we never think about that.
Yep.
That's great. Look, but would there be any implications of joint replacement or any complications?
Oh, there's complications of the surgery. It's a big operation. We're doing that operation in the older age group, so they'll have medical risks. Also, there's always a risk of infection. Because you have artificial material in the joint, if infection gets into that joint, and particularly unfortunately today with some of the more resistant bacteria to antibiotics, if those infections get into a joint, it can be a very poor outcome for them. But that's small numbers, thankfully. The second complications that can occur immediately after the operation is risk of blood clots. But there's a lot of treatment today that can help doing that. The other complications and the reasons why patients sometimes need reoperation after a knee replacement is not because they wear out, but sometimes, apart from infection, the anchor points which connects the prosthesis to the bone can work loose. It can work loose because of some problem with the bone itself. It can work loose for many other reasons, trauma or falls, or just sometimes the body just doesn't fix the implant in as solidly as what it should.
Dr. Courtenay, how many joint replacements are done in Australia?
Yeah, in Australia at the moment, there's almost 60,000 knee replacements done a year, and there's over 40,000 hip replacements done a year. A number of the hip replacements are done for fractures, but the rest of them are done for arthritis. So it's a large number, and there's a large amount of implants and companies who are working and helping to produce a market for these implants in Australia.
Earlier you mentioned a joints register.
Correct.
May you please elaborate on that, please?
In the late 1980s, in response to a problem with identifying faulty heart valves, the Orthopaedic Association was approached, and it was recommended that they consider supporting the voluntary registration of all joint replacements done in Australia. So the Orthopaedic Association, with government funding, started to record the joints performed in Australia. And in 1999, it started as a pilot project. 2001, it was rolled out to a national exercise. And today, there's well over 800,000 implants recorded in that joint register. With the support of Medicare and government facilities, they are tracked through. So we're in a position now that we can actually work out what works and what doesn't work. One of the more significant outcomes of the joint register, I believe, is the identification of that metal-on-metal hip that I spoke about earlier, where there were high levels of chrome and cobalt. The Australian Joint Register recognised very early on that there was a problem with this implant. We did 5,000 of these in Australia before it became really obvious. Worldwide, they did 95,000. And nowhere else in the world did they have the evidence to show that it was at fault, this prosthesis. So the Joint Register is voluntary by all of the surgeons, all of the hospitals that perform joint replacements around Australia. It's close to 100% capture. And I say close to it because you can't get 100% all the time, but every effort is done to make sure that data is accurate. And today it is probably the most significant document, certainly in Australia, and one of the more significant documents in the world to tell us what works and what really doesn't work in joint replacements. Today we have hips and knees there, shoulders and the other joints are being added with time.
So where most of the 5,000 those joint replacement being replaced?
Yes.
All of them?
No.
Unless the patient...
No, what happened to those 5,000, the particular ones, the patients were all notified that they'd had an implant. That was done through the company and also through their individual surgeons. Patients then had a series of blood tests to see if they were the ones at risk. Not every one of those metal-on-metal hips was a problem. It was only those that was giving the binding and giving high levels of continuing levels of chrome and cobalt in their body, because the body couldn't get rid of the excessive chrome and cobalt. Those that didn't have a problem with chrome and cobalt blood levels, their hips are fine and will probably last forever for them. But it was a percentage, it was about 15% of them. Far higher than what we would like to see, but it was still a lot of them were doing very well. But nevertheless, there was a real problem. So these patients are being closely monitored at the present time.
Dr. Courtenay, before we finish, joint replacement doesn't have any effects or impact on other parts of the body, or would it hinder, for example, diagnostic examinations or like MRI, CT, or any other treatments?
Yeah. The You can have an MRI after a joint replacement because the materials are not adversely affected by it. However, an MRI in the vicinity of an implant will give a lot of artefact and defect because of reflection and altered flux of the magnet. But it's quite safe to have an MRI after a joint replacement. And all joints today, they're either made out of the chrome cobalt steel or titanium alloy, and they're quite safe in an MRI scanner and to do that. In the future, it's unlikely that there will be different materials for a particularly long period of time because of the difficulty of getting proof of new materials being safe in the body. It really is a matter of you have to prove that they are not going to cause a problem 20 years now, and it's pretty difficult to prove a negative. So I think at the moment, unless we have some more novel approach to joint replacements, the osteoarthritis of the hips and knees, we'll be looking at joint replacement for probably a very long time to come in one form or another.
Thank you, Dr. Courtenay, for coming tonight. It was very informative, and we'll wait for our viewers to have their request, and we might have to invite you again.
Thank you very much, James.
Thanks for our viewers for watching the episode, and we will be waiting for your feedback and see what other questions you have for Dr. Courtenay. And thank you for watching, and see you next time.